For a case of vision loss, using our mnemonic old cards as our guide, we'll note the onset, or when did it start. Did your vision loss come on suddenly, or was it more gradual? Is it in your right eye, your left eye, or both? For the duration, we'd like to note if the loss has been constant since it started, or is it more intermittent? And if that's the case, we'd like to note the frequency. How long does your episode of vision loss last, and how many episodes are you having per day or per week? Next, we can note the progression. Are the episodes occurring more frequently, or is your field of vision decreasing? Or, if there is no progression, we'll also be sure to state that in our patient note to show that we asked. To characterize the vision loss, we'd like to clarify if it's near or far-sighted, peripheral or central, or if there's any associated eye pain. Aggravating and alleviating factors, radiation, treatments tried, and severity on a scale of 1 to 10 if there is pain. And again, if there are no aggravating and alleviating factors, radiation, or treatments tried, we'll also be sure to state that in our patient note to show that we asked. We'll break down our case of vision loss into the young, a mix, and the old. For all cases, let's order a CBC, serum electrolytes, a dilated fundus examination, an eye examination to measure pressure, and eye angiography. Starting with the young, in multiple sclerosis, we'll see vision loss or double vision, numbness, tingling, a motor weakness, ataxia, and it can be aggravated by warmth and Uthoff sign. We can also see urinary incontinence, and a positive internuclear ophthalmoplegia and a Lermite sign on our physical exam. And we'll add to our workup an MRI of the brain and spine. In myasthenia gravis, we'll see diplopia, ptosis, muscle weakness, and it will all be aggravated by use or towards the end of the day. And we can have a history of hypothyroidism. And we'll add an anti-acetylcholine antibodies, a tensilon test, and an electromyography. In hypertensive retinopathy, we'll see progressive visual loss with a headache and a history of hypertension or coronary artery disease. In diabetic retinopathy, we'll also see progressive visual loss, now with peripheral neuropathy and a history of diabetes, and we'll add a serum glucose and A1C. In presbyopia, or age-related farsightedness caused from a decrease in lens elasticity, we'll have nearsighted vision loss, and it can be alleviated by a relative's reading glasses, and our patient will typically be older. In macular degeneration, we'll have central vision loss. Our patient will be older with a history of smoking or hypertension. In a retinal tear, the age vitreous gel loses its form and begins to pull on the retina, and we'll see peripheral vision loss, and it can be described by our patient as a curtain being drawn down. It can be preceded by flashes from the stressed retinal photoreceptors or floaters from cells or blood released in the tear. Our patient will be older with possibly a head trauma. In glaucoma, an increase in intraocular pressure can cause both open or closed angle. In open, the iris angle remains open, but because of an aged or clogged drain, we'll see painless or a peripheral vision loss. In closed, the iris angle is now close to outflow, and so we'll have now painful. It will be acute. We can also see halos and conjunctivitis with headache and nausea and vomiting. And since vomiting is a bodily fluid, we know by now to use our mnemonic A, B, and C to write down for our patient note the amount, if there's any blood, and the color of the vomitus. In a retinal artery occlusion or an eye stroke, we'll see acute, painless, monoocular vision loss, and our patient will have a history of risk factors, hypertension, diabetes, atrial fibrillation, cholesterol, and smoking. And we'll add here an ultrasound of the carotids and an echocardiogram to try to get at the source of the stroke. In a giant cell or temporal arteritis, we'll also have monoocular vision loss. We could also see a headache in the temple area. It can be aggravated by chewing or jaw claudication. Our patient will be older and possibly with a history of polymyalgia rheumatica. And again, our patient may not give us this nice differential and instead may complain of pain or stiffness in the shoulders and hips in the review of symptoms. And we'll add here an ESR-CRP and a temporal artery biopsy.
We'll start our neuro exam with hand sanitizer, and we want to ask our SP if we have permission to examine them.
Yeah.
Okay, and we're going to start with a hint exam, and we're going to use it as a guide to help us out. So for the head, we could comment that it's normocephalic, atraumatic. For a case of vision loss or headache or hypertension, we want to do a little bit more complete eye exam. So to do this, we'll get out our fundoscope here, and we're going to use the same eye as the patient's eye. So we're going to use my right eye and his right eye. And so ask him to keep looking straight ahead, and we could verbalize that there's no fundoscopic lesions and he has no AV nicking or hemorrhages. And also, if this were a visual intensive case, we would assess peripheral vision. So we could ask him if he sees this coming.
Mm-hmm.
Okay, and do you see this
Yes.
coming? Okay, we could do the same thing from up
Yes.
top. Okay, good. And then we can now transition to the cranial nerve exam. For cranial nerves, 1, we don't really assess cranial nerves, so we could kind of use that as a hint or as a placeholder to test their alertness and their awareness. So we could ask them, what is their name?
Glitching.
And where are we right now?
The clinic.
Okay, good. And what time of day is it right now?
Afternoon.
Good. So now we could verbalize that they were alert and oriented times 3. Okay, now we could transition to the rest of the cranial nerve. So for cranial nerve 2, ask them to look straight ahead, and we're just going to check their pupillary constrict the response, and then we're going to do the same thing on the other side. We're going to do the same thing here, and then we're going to do it on the other side. Good. Now we could verbalize that they were pearl, if pupils were equal and reactive. We're going to transition to cranial nerve 3, 4, and 6. So please, you'll instruct them to please follow your fingers with their eyes, keeping their head straight, and you can see that he's able to follow. Okay. Trigeminal nerve, cranial nerve 5, and we're going to assess this with sensation. So please close your eyes and let me know if this is equal.
Mm-hmm. Mm-hmm.
Okay, good. So for cranial nerve 7, we're going to go ahead and ask him to please smile, puff out your cheeks. Okay, don't let me pop them. Close your eyes real tight, don't let me open. Cranial nerve 8, and we'll ask him to please close your eyes and let us know what side you hear this.
Left.
Okay, you hear this louder on your left?
Yeah.
Okay, good. So that would be a concern now if he has hearing loss on his right hand side. So continue with cranial nerves 9 and 10. So you could ask him to say "ah," please, and we would try to stick out your tongue, and we would visualize that we could see a non-deviated uvula. And while he's out here, we could also ask him to move his tongue left to right, and we could say that his hypoglossal nerve, cranial nerve 12, is intact. And now we will finish up with the cranial nerve 11. So please shrug your shoulders. Okay, so they're equal. And look that way and resist me. Okay, and look this way and resist my movement. Good. And now we're going to continue with MSRP. So for motor strength, please make a muscle for me. Okay, and resist me. So 5 out of 5, full reflection, and extend 5 out of 5 on extension. Great. Now we're going to do sensation to light touch. So please close your eyes and let me know if you feel this equally on both sides.
Yes, I do.
Okay. Now we're going to do a pinprick. So please let me know if you feel this on your left.
Oh, yeah, I feel it.
Okay. Now we're going to do the same thing on your right. We're going to do our reflex. So we're a biceps reflex. Place our thumb on the biceps tendon and instruct to just relax, please. Okay. We should get a 2+ response. We'll do the same thing on the other arm, and then we could verbalize we have a 2+ response bilaterally. And now we're going to assess the pulses. So we'll get a radial pulse, and we'll check on the other arm as well, and then we could verbalize that we have a 2+ radial pulse bilaterally. For motor strength on the lower extremities, could you please kick out? Okay, good. So that's 5 out of 5. Now could you please kick in? Good, 5 out of 5. Now we'll go into sensation. So please close your eyes and let me know if you feel this equally on both sides.
Yes, I do.
Okay, great. And now we're going to go into pinprick. So this is a pinprick. I'm going to start on your left side, and please let me know if you feel this all the way down.
Yes, I feel it.
Okay. And now I'm going to go onto your right side, so please let me know if you feel this.
Yes, I do.
For neuropathy, he may not have good proprioception. So if we ask him if this is the up position and this is a down position, where are we now? Are we up or down?
I don't know.
So he may say he doesn't know, and that would confirm that he has lost his proprioception for his patella as well. I want to ask him to relax and assess his patellar reflex. Okay, good. And now tap on his Achilles tendon. So we'd start right here, and we would get a normal reflex. We could also test while we're down here a Babinski. So we could start on the bottom of the sole and go into the big toe. And note, if he had a positive Babinski, his toes would curl up. For the pulse, we're going to go behind the medial malleoli, and we'll feel for the pulse, 2+ pulse. And then we could do the same thing on the left extremity and verbalize we have a 2+ bilaterally. Okay, now that we've finished with the lower extremity, we'll go ahead and hand sanitize again. And we'll ask our SP if they could please stand up and take some steps. Okay, can you turn around, please? So we're noting We'll go ahead and listen to the heart sounds. The mnemonic we want to use is department M225A. That stands for the aortic, so we'll check that aortic first in the second intercostal space on the right. And then we're going to go to the pulmonic side. Go to the tricuspid. And then we're going to go to the mitral. And if this was a female patient, a tip you could use is to lift their breast up. Okay, we can make a comment that we heard a regular audible S1, S2, no murmurs, rubs, or gallops. Next thing we're going to do is go ahead and listen. And we'll start off listening. We'll switch it over to the bell, and we'll use that to listen above the clavicle. And the instructions you want to give is, when you feel my stethoscope, please breathe in and breathe out.